Hello everyone, it's Eric from Strong Medicine. Today I'm discussing an approach to acute abdominal pain. Diagnostic frameworks for acute abdominal pain are either based on anatomic region or by organ system, with the former more common. If using the region to organize the list of possible diagnoses, the abdomen can be divided into 4 quadrants, with the umbilicus at the center. However, it's probably even better to divide it into 9 regions: right upper quadrant, epigastric, left upper quadrant, left flank, left lower quadrant, suprapubic, rarely called hypogastric, right lower quadrant, right flank, and periumbilical in the center. Because this 9-region framework is the most common, let's take a closer look at it. When trying to consider what diseases might cause pain located in a certain region, the simplest principle is to consider what structures are within that region. So pain in the right upper quadrant suggests liver or biliary pathology, while pain in the left upper quadrant could be from the spleen. Now I'm going to go through specific etiologies while traveling around the abdomen, starting in the epigastric region. Pain located here can be from gastroesophageal reflux disease, gastritis, peptic ulcer disease, gastroparesis, most commonly a complication of diabetes, pancreatitis, and occasionally referred pain from acute coronary syndrome. Pain in the left upper quadrant can be from a splenic infarct, splenic abscess or splenic rupture, a subdiaphragmatic abscess, or referred pain from a left lower lobe pneumonia. Pain in either flank can be from nephrolithiasis, pyelonephritis, which is infection of the kidney, or a perinephric abscess, which is an abscess adjacent to the kidney. Periumbilical pain is most commonly from simple viral gastroenteritis, but could also be from a small bowel obstruction, mesenteric ischemia, which is like angina of the gut, and a ruptured abdominal aortic aneurysm. Suprapubic pain can be from cystitis or a simple urinary tract infection. Pelvic inflammatory disease, which is a severe complication of sexually transmitted infections seen in women, or an ectopic pregnancy, which occurs when an embryo is implanted somewhere other than the uterus, a condition which results in a non-viable pregnancy and is life-threatening to the mother. Pain in the right and left lower quadrants have similar pathologies, including ovarian and testicular torsion, a ruptured ovarian cyst, a tubo-ovarian abscess, and ectopic pregnancy. 2 differences between the left and right lower quadrants. Appendicitis pain is located in the right lower quadrant only, unless the patient has an unusual anatomic variation in the position of the intra-abdominal organs, and diverticulitis is more common on the left than on the right. Last is the right upper quadrant, which I think of as a more distinctive entity than the others, on account of particularly complex and numerous potential liver and biliary pathologies there. So let's take a look at that region a little more closely. We can divide etiologies of right upper quadrant pain into those from the liver, those from the biliary system, and other. Etiologies of hepatic pain can be divided into infectious and non-infectious. Under infectious is acute viral hepatitis and a liver abscess. Non-infectious causes include alcohol and medication-induced hepatitis, hepatic congestion from heart failure, and Budd-Chiari syndrome caused by obstruction of the hepatic vein. Biliary pathologies can also be divided into infectious and non-infectious. Under infectious are acute cholecystitis, which is inflammation and infection of the gallbladder, and acute cholangitis, which is inflammation and infection of the common bile duct. Relevant non-infectious pathologies of the gallbladder include simple gallstones, which lead to a condition known as biliary colic, and choledocholithiasis, a mouthful that means a gallstone trapped within or actively passing through the common bile duct. Lastly, in the other causes of right upper quadrant pain are referred pain from a right lower lobe pneumonia and a right-sided subdiaphragmatic abscess. There are some etiologies of acute abdominal pain that can be either generalized or poorly localized, including inflammatory bowel disease, infectious colitis such as C. difficile, spontaneous bacterial peritonitis occurring in patients with chronic ascites, secondary peritonitis, typically occurring from bowel perforation, and diabetic ketoacidosis. Some relatively rare but nevertheless important causes of acute abdominal pain: adrenal insufficiency, acute intermittent porphyria, and abdominal migraine, angioedema, which sometimes surprises people since we are more familiar with angioedema causing swelling of the mucous membranes of the face and throat, but the same process can occur in the gut, colonic pseudoobstruction, herpes zoster, in which the pain can occasionally precede the onset of the unilateral vesicular rash by a few days, and a rectus sheath hematoma. Let's bring back the abdomen picture to make a few more points about location. Some etiologies of abdominal pain have common patterns of radiation. For example, pyelonephritis typically radiates around the flank to the lateral back, while nephrolithiasis radiates to the groin. Hepatic and biliary pathology often radiates to the right shoulder, and pain from pancreatitis and AAA can radiate straight backwards. When it comes specifically to appendicitis, there is a classic migratory pattern to the pain. Early appendicitis, triggering just visceral pain fibers, is first felt not in the right lower quadrant, but rather in the periumbilical area, where its actual location is kind of vague and not yet associated with tenderness. In the next phase, as the peritoneum overlying the appendix becomes inflamed, the pain is now felt more in the right lower quadrant and is associated with significant tenderness. And the late phase, if the appendicitis is not identified and treated in a timely fashion, perforation occurs, leading to generalized pain along with peritoneal signs from secondary peritonitis. Visceral pain fibers poorly localize compared to somatic fibers that innervate the peritoneum. As a consequence, despite the specific anatomic framework I reviewed earlier, pain does not always map neatly to specific abdominal quadrants or regions. For example, visceral pain from foregut structures is most common in the epigastric region, but can be found in either the right or left upper quadrants or near the umbilicus. Pain from midgut structures can extend into the epigastrum and suprapubic regions. Hindgut structures can lead to pain throughout half the abdomen. Pain from the GU system and reproductive systems can be widespread, and even pain from the liver and biliary system can extend outside the right upper quadrant. Now, I'll shift to discussing the step-by-step evaluation of abdominal pain, starting from the history. One of the most important questions is the chronology of the pain. For example, its acuity of onset. An extremely abrupt onset suggests bowel perforation or vascular catastrophe, including intra-abdominal thromboembolism, ruptured AAA, and ovarian or testicular torsion. How long has the pain been present for, and whether it is episodic or continuous? As a general rule, episodic pain suggests a less imminently dangerous pathology such as biliary colic, peptic ulcer disease, GERD, chronic mesenteric ischemia, and gastroparesis. But that rule isn't perfect, since intermittent epigastric pain could be an atypical presentation of acute coronary syndrome. As I just reviewed, the location and radiation of pain is helpful at narrowing down diagnostic possibilities. Determine what the exacerbating factors are. For example, pain related in any way to food intake suggests either upper GI, pancreatic, or biliary pathology. Ask about the presence of associated symptoms, including nausea and vomiting, diarrhea or constipation, evidence of GI bleed, lack of flatus or passing gas, fever, jaundice, dysuria, or hematuria. Obviously, take a past medical and surgical history, and a gynecological history too. Medication history, sexual history for STI risk factors, substance use history, particularly alcohol, travel history, and a general exposure history. After vitals, a focused physical exam should of course include a thorough abdominal exam, and if any type of reproductive pathology is on the differential for a female patient, a pelvic exam. Since cardiac and pulmonary disease can refer to the upper abdomen, those exams should be performed as well. You may notice here that I have not listed a rectal exam. That's because it's generally not indicated unless anal, rectal, or prostatic disease is specifically suspected. Key labs in the workup of acute abdominal pain include CBC, LFTs, metabolic panel, and a lipase, the last of which is specifically to help identify pancreatitis. Historically, another test called amylase was also frequently ordered in this presentation, but it's nonspecific and does not contribute useful information. Other frequently considered tests: if the patient is a woman of childbearing age, get a urine HCG to screen for pregnancy, even if she reports no sexual activity. Patients are sometimes not forthcoming, and an ectopic pregnancy is not a diagnosis you or your patient can afford to miss. If acute bowel ischemia is suspected, an elevated lactate would be consistent with infarction. Unless the patient is young, healthy, and without cardiovascular risk factors, order a troponin and an ECG to rule out acute coronary syndrome. If the pain is upper abdominal or the patient has concurrent pulmonary symptoms, order a chest x-ray. If the patient reports either dysuria or hematuria, check a UA plus or minus urine culture depending on suspicion for a urinary infection. And there are numerous indications for either a CT, ultrasound, or rarely other imaging modality. While as a general rule, at least in the United States, clinicians over-rely on imaging in most circumstances, in my experience, acute abdominal pain is not one of them. At this point in my approach to symptom videos, I usually present a diagnostic algorithm that one could follow to arrive at the single most likely diagnosis. But with acute abdominal pain, there are just too many etiologies to reasonably include in one algorithm. So instead, I'm going to review a handful of illness scripts for some of the most common diagnoses, which will compare and contrast typical historical features, risk factors, common exam findings, and the relevant diagnostic tests. I'll divide these scripts in half, starting with causes of general and or more midline pain, and will then separately compare and contrast the 4 most common causes of right upper quadrant pain. First, let's compare and contrast peptic ulcer disease, gastroenteritis, small bowel obstruction, appendicitis, and pancreatitis. In PUD, the pain is epigastric, occasionally radiating to the back. It may be triggered by eating. There is occasionally associated nausea and vomiting and or overt signs of GI bleeding like melena, but these are usually absent. Risk factors include NSAID use and H. pylori infection. Physical exam can show mild to moderate epigastric tenderness. If there are peritoneal signs present, the ulcer has likely perforated and needs a surgeon. Routine blood tests are usually unremarkable unless the patient has significant bleeding. PUD is diagnosed via EGD, which should be supplemented with testing for H. pylori. When it comes to gastroenteritis, pain is typically periumbilical. It's often crampy and associated with nausea and vomiting and diarrhea in most cases. There aren't really significant risk factors outside of an outbreak. The exam will show mild to moderate periumbilical or generalized tenderness, but no rigidity or peritoneal signs. Fever and signs of dehydration are common. The only typical abnormal blood test is an elevated white blood cell count. Diagnosis is a clinical one, not requiring any imaging or endoscopy. In just the last several years, some U.S. medical centers have begun employing stool PCR panels for some patients presenting with diarrhea in order to identify the specific pathogen. Like gastroenteritis, the pain from a small bowel obstruction is typically periumbilical and crampy. It's associated with nausea and vomiting, abdominal distension, and an absence of flatus. Risk factors for an SBO include prior abdominal or pelvic surgery, hernias, foreign body ingestion, inflammatory bowel disease, and an intestinal tumor. The exam usually shows abdominal distension. There may be high-pitched rushing bowel sounds. There may be signs of dehydration. And peritoneal signs suggest perforation or infarction. Even though an SBO can usually be diagnosed on history and exam alone, these patients should all get a CT to identify the location of the obstruction and to search for potential causes. If for some reason CT is not available, plain films are a reasonable alternative to definitively confirm the diagnosis, in which case upright and supine abdominal film should be ordered, plus or minus an upright chest X-ray, which can better identify the presence of free air. As already discussed, pain from appendicitis is classically present in the right lower quadrant, but often begins in the periumbilical region. Nausea, vomiting, and anorexia usually follow the onset of pain rather than the other way around. If there is severe generalized pain, perforation is likely. There are no major risk factors for appendicitis. On exam, the most notable finding is tenderness at a specific location called McBurney's Point, which is located 1/3 of the distance along an imaginary line from the anterior superior iliac spine to the umbilicus. There are some other classic but less discussed findings, such as Robsing's, psoas, and obturator signs. Patients are often febrile. And once again, peritoneal signs suggest perforation. Significant labs in appendicitis include high white count and an elevated CRP. While an elevated CRP would be expected in some other abdominal diseases, such as peritonitis and acute cholecystitis, for some reason it's more discussed as a feature of appendicitis specifically. There is also a clinical prediction rule called the Alvarado score, which assigns points to various historical, exam, and lab features to give an overall probability of the diagnosis. Any patient with suspected appendicitis should undergo imaging, which can be either CT or ultrasound, the choice of which is institution, clinician, and situation dependent. And then there is pancreatitis, in which patients present with epigastric pain radiating to the back that's exacerbated by eating and relieved by sitting up and leaning forward. It's usually associated with nausea and vomiting. Dyspnea is a more commonly associated symptom in pancreatitis than with the other diagnoses in this chart. Risk factors or etiologies for pancreatitis include alcohol and gallstones, which together account for the majority of cases. Less common causes include ERCP, hypertriglyceridemia, and a variety of medications. On exam, severe cases can present with shock. And periumbilical or flank ecchymoses suggest hemorrhage secondary to pancreatic necrosis, a particularly worrisome sign. The most notable abnormal lab is in very elevated lipase, typically more than 3 times the upper limit of normal. While a CT scan is not considered necessary for the diagnosis, it can assess for complications and help identify gallstones in the pancreatic duct as a potential causative factor. Now, let's run through the illness scripts of 4 particularly important causes of right upper quadrant pain: biliary colic, acute cholecystitis, acute cholangitis, and acute hepatitis. In biliary colic caused by gallstones within the gallbladder, the pain is typically episodic, lasting 30 minutes to several hours. It's often triggered by eating. There is no associated jaundice. Risk factors include female sex, pregnancy, obesity, rapid weight loss, and diabetes. The physical exam is usually unremarkable, as are routine blood tests. A right upper quadrant ultrasound will show gallstones and help to clinch the diagnosis, but this is a non-emergent study if the clinical presentation is classic. The pain in acute cholecystitis is progressive over hours. Nausea and vomiting are common. And since the common bile duct is not involved, there is no jaundice. The most notable risk factor for acute cholecystitis is the known presence of pre-existing gallstones. On exam, patients are often febrile. The classic finding is an increase in right upper quadrant tenderness on inspiration when the diaphragm descends, pushing the liver and gallbladder into the examiner's stationary hands. This is known as Murphy's sign. There's also something called the sonographic Murphy's sign, in which pain is worse with inspiration when the pressure is applied to the right upper quadrant with an ultrasound probe at the exact location of the gallbladder, since the examiner can directly see it on the screen. This is thought to be more specific than the classic Murphy's sign. Routine lab tests usually reveal an elevated white count with normal or near normal LFTs. A definitive diagnosis can usually be made with a right upper quadrant ultrasound. In acute cholangitis, the pain is similar to acute cholecystitis, and nausea and vomiting are also common. However, jaundice also occurs. Risk factors for acute cholangitis include benign biliary strictures and malignant obstruction of the biliary system, including pancreatic tumors. As a very general rule, Patients appear more ill than in other common causes of right upper quadrant pain, but this is less often the case in the elderly and in those on immunosuppressive medications. Common test findings include a high white count, high bilirubin, which is predominantly direct or conjugated bilirubin, high alkaline phosphatase, and there may or may not be mild to moderate elevation of AST and ALT. If, after the history, exam, and blood tests, the pretest probability of cholangitis is high, one can proceed directly to an ERCP. Otherwise, consider a right upper quadrant ultrasound. And the last diagnosis to discuss is acute hepatitis, which is acute infection and/or inflammation of the liver. The symptoms of acute hepatitis can be similar to those of acute cholangitis, though in my experience, the onset is slightly more prolonged. Risk factors, or more appropriately, etiologies here, include hepatitis viruses, particularly A, alcohol, acetaminophen toxicity, and autoimmune hepatitis. There are many other causes of acute hepatitis, but these four cover the overwhelming majority in the US and other Western countries. On exam, fever is sometimes present, and there can be a variety of findings related to liver dysfunction depending upon the severity and acuity of presentation. Labs include high white count, extremely elevated AST and ALT, often over 1,000, high alk-phos, high bilirubin, classically with direct and indirect being roughly equal, and an elevated INR. Other tests you should order include hepatitis virus serologies, an acetaminophen level, though a single number is impossible to interpret in the absence of a known time of acute drug ingestion. Also, if another etiology of the hepatitis has not been clearly established, autoantibodies for autoimmune hepatitis are reasonable to order. When discussing acute abdominal pain, it's common to hear the term surgical abdomen. Use of this term implies that the underlying etiology requires an emergent evaluation by a surgeon. Specific exam characteristics that are consistent with a surgical abdomen include rigidity, also known as involuntary guarding, which is the most concerning of abdominal physical findings, unusually severe tenderness to palpation. Signs of peritonitis, known as peritoneal signs, include rebound tenderness. This is the finding that pain caused by slow abdominal pressure applied by the examiner's hands is not as severe as the pain caused by the quick release of that pressure. It includes a positive cough test, in which pain is worsened by coughing, the bed bump test, in which it is worsened by the examiner bumping the bed hard, which works best on a gurney rather than a sturdy hospital bed, or the heel strike test, in which pain is worsened by the examiner firmly striking the patient's heel. In ambulatory patients, the heel strike test can be done by asking the patient to stand and jump in place. And absent bowel sounds. None of these findings in isolation necessarily indicate a surgical abdomen, but seeing multiple of them in a patient whose history is consistent with a possible surgical emergency would suggest this general situation. Also, not every surgical emergency presents with a surgical abdomen. Specifically, emergencies which are extraperitoneal, such as a ruptured aortic aneurysm. The term surgical abdomen is sometimes used interchangeably with the term acute abdomen, although some clinicians use the latter term more broadly to mean any patient with acute abdominal pain and any notable physical exam findings, irrespective of likely pathology. Finally, I'll end by listing those conditions to particularly consider in patients with abdominal pain who are presenting with shock at the time of initial presentation. These include acute cholangitis, bowel perforation, bowel infarction, ruptured ectopic pregnancy, ruptured AAA, splenic rupture, any condition with concurrent massive GI bleed, and an acute myocardial infarction. The key takeaway points for this video. Acute abdominal pain is one of the most common presenting symptoms to the emergency room and urgent care. There are many etiologies ranging in severity from benign and self-limited to imminently life-threatening. Etiologies are associated with specific locations of pain, but they do not always map as precisely to anatomic quadrants as references typically suggest. Abdominal pain can be referred from intrathoracic pathologies. And finally, the presence of rigidity, unusually severe tenderness to palpation, peritoneal signs, and absent bowel sounds are consistent with a surgical abdomen, which usually requires emergent surgical consultation.